Hi, I am Vera Bukkems, and today I will present to you our study that assesses subtherapeutic exposures in pregnant women living with HIV treated with Raltegravir 1200 mg once daily. These are our disclosures. Those of you who have been pregnant know that your body completely changes during pregnancy. These physiological changes influence the absorption, distribution, metabolism, and elimination of drugs. As depicted on this slide, a variety of physiological processes changes, making it difficult to predict the resulting drug exposure in pregnant women. From previous research, we know that the drug exposure is generally decreased in pregnant women. Decreased drug concentrations mean that the person is at risk for inefficacious treatment. In a woman with clinically relevant lower drug concentrations, the viral particle replicates and becomes detectable. Next to affecting the woman's own health, adequate treatment is of particular importance in pregnant women to prevent mother-to-child transmission of HIV. This prevents infecting the baby with a lifelong chronic disease. It is not feasible to perform a large clinical trial examining the virologic failures in pregnant women. Therefore, we evaluate the efficacy of antiretroviral drugs by measuring drug concentrations in pregnant women and base the efficacy on the exposure-response relationship. The most important parameter in the monitoring of antiretroviral drugs is assumed to be the concentration before next dose administration, the C-trough. This has to be high enough to continuously inhibit the replication of the HIV virus. In this study, we examined the pharmacokinetics of Raltegravir during pregnancy. Raltegravir exists in two formulations. The first Raltegravir regimen existed of one tablet 400 mg twice daily, 400 mg BID. In 2017, the Raltegravir 600 mg tablets received market authorization. These tablets have to be dosed as two tablets once daily, 1200 mg QD. This new formulation enabled an easier and more patient-friendly regimen as a result of the less erratic absorption and decreased influence of concomitant food intake. This regimen showed non-inferior efficacy and safety to the former 400 mg BID regimen. However, a pharmacokinetic study of multiple dose pharmacokinetics in fasted states showed that the mean C-trough is 38% lower when dosed in this regimen. Theoretically, this means that this regimen is more sensitive to concentration-lowering influence, like drug-drug interaction. The former 400 mg is a preferred antiretroviral drug in pregnant women in Europe and in America because of the increasing good experience, no safety signals, and the potency to quickly decrease the viral load. However, no data exists for the new regimen. Therefore, this regimen is currently not recommended in pregnant women. Collecting data is challenging in this group because of the alternatives. Therefore, we aim to develop a POP-PK model for Raltegravir. With this model, we aim to predict the pharmacokinetic profile of Raltegravir 1200 mg QD in pregnant women, and on basis of the pharmacokinetic profile, we could discuss the expected pharmacodynamic characteristics of Raltegravir 1200 mg QD in pregnancy. We started building this POP-PK model with the data of 96 non-pregnant subjects using the 1200 mg QD Raltegravir regimen. The geometric mean concentration time curve of these data is shown on the left. With POP-PK modeling, we estimated the typical values of the PK parameters used to describe this curve, like clearance and central volume of distribution. We also estimated the variability in these PK parameters to access the curves of all individuals. Furthermore, we examined if patient characteristics, interacting drug co-administration, HIV infection itself, and different meal types could explain the variability between subjects. Subsequently, we added the data of 103 non-pregnant subjects using the 400 mg BID regimen to describe the typical PK curve showed in light blue. This enabled us to estimate the difference effects of the 600 mg versus the 400 mg formulation. Then we added the steady-state data of 22 pregnant women, showed in black, from the PANNA study to estimate the influence of pregnancy on Raltegravir pharmacokinetics. Finally, we aim to predict the PK parameters of Raltegravir 1200 mg QD in pregnancy, the gray curve. We run Monte Carlo simulations of 3,000 pregnant women 1,000 times with multi-level random effects. We repeated these simulations under 3 conditions: fasted, low fat, and moderate fat state. As a proxy for efficacy, we compared the C-trough of pregnant women on the 1200 mg QD regimen to the C-trough in non-pregnant women using the same regimen. The lower bound of the 90% confidence interval of this ratio was defined to be above 0.75. This is similar to the target established in drug-drug interaction studies by the manufacturer. The secondary outcome parameter was the proportion of individuals with a C-trough below 0.02 among pregnant compared to non-pregnant women using the 1200 mg QD regimen. This target was derived from the receiver operating characteristics curve from the pharmacokinetic data of the 800 mg once daily studies. This regimen was shown to be inferior to the 400 mg BID regimen. The final model structure is shown on the left. A two-compartment model with first-order elimination and absorption to 3 sequential absorption compartments best describe the data. The table on the right shows the typical parameter estimates of our model. I want to point out that we assessed that the bioavailability is 21% higher in individuals using the 600 mg tablet compared to the 400 mg tablet. This is similar to pharmacokinetic studies with these tablets. We also estimated a 49% decrease in bioavailability in pregnant compared to non-pregnant women. The visual predictive check indicated an adequate model fit to the observed concentration time data. The median and confidence interval of the observations, red and blue dotted line, overlap with the simulation, the blue and red shaded areas. So, do the simulations suggest efficacy of the once-daily regimen in pregnancy? The geometric mean ratio of pregnancy-non-pregnancy was 0.51 and the lower bound was 0.41, so the lower bound was below our target of 0.75. Also, we simulated that a large proportion of the pregnant women using the 1200 mg QD regimen had a C-trough below target. In the worst-case scenario, a low-fat meal, 59% of the women had a C-trough below target. We were able to verify our modeling results with the first clinical data of the PANNA study. 2 women who were treated with Raltegravir 1200 mg QD during pregnancy were included in this study. The C-trough ratios, pregnancy postpartum, of these women were 0.46 and 0.52 and were similar to our modeling results. Both women had an undetectable viral load at 3rd trimester and delivered healthy babies. To discuss, Raltegravir plasma concentrations are highly variable in and between subjects, impeding model development. Therefore, we run our simulations with multi-level random effects and included parameter uncertainty. We had to assume as well that the effect of pregnancy is similar for the 600 mg as for the 400 mg formulation. Theoretically, this will be true for the pregnancy effect on the volume of distribution and elimination because the active substance is the same. However, the effects on absorptions may be different. We made a C-trough target as secondary and not primary target because of the low sensitivity of this parameter. Also, no relationship between a low C-trough and virologic failure could be observed in a phase 3 study with the 1200 mg QD regimen. So, to conclude, we estimated that the bioavailability of Raltegravir is typically 49% lower in pregnant compared to non-pregnant women, and our primary target for efficacy was not met, suggesting inadequate Raltegravir exposure during pregnancy. However, the clinical data of 2 cases suggests inadequate viral suppression despite these low concentrations, but 2 cases do not have enough power to conclude something about clinical outcomes. Therefore, a conservative approach restraining the use of the QD regimen in pregnant women seems reasonable until additional research confirms that a lower Raltegravir exposure is clinically effective. I would like to thank Merck for sharing their data and all involved in the PANNA study, and special thanks to Elin and Teun for sharing their expertise on PAP-PK models.